and welcome to Critical Care Northampton with Johnny Wilkinson. Today we're going to be discussing all things inotropes and which one's best for your patient. Enjoy.
It's time to delve through the best papers. My God, check those infographics. It's the best out there for phone it and all things critical care. You want to check the best on X? It's just the best POCUS. My God, is there a podcast better than mine? Check out the crazy websites. Critical Care Northampton. Ladies and gentlemen, welcome to the very first Northampton, Critical Care Northampton vlog. It's also going out as a podcast, so whoever is listening in the podcast version, I'd encourage you to go onto YouTube and tune into the channel on there, and you can see, unfortunately, me and my various guises of face, and you can also see what I'm talking about. So if you're listening on the podcast, we are describing a few things that are graphical on screen, and I'm hoping you may get the gist if you're listening in your car or whatever. Hopefully you're not watching in your car unless you're driving a Tesla on autopilot, but that's very naughty. So what I want to do is run through some of the best papers, some of the best things out there in critical care from a couple of weeks of trawling, certainly Twitter and various other platforms like that. So without further ado, we are going to go off to a document which I will make available through a link, a QR code on the website and via the YouTube channel at the bottom. So here we go. Let's have a look and see what I've been pulling out from Twitter and so forth. So the first thing is we have some news for you all.
This is the news section.
Thank you, Emily. That's my daughter. She did a few jingles. And by the way, I'm Johnny Wilkinson. I am a critical care consultant and anaesthetist from Northampton. But I just want to point out that everything on here and the views I express are nothing to do with the hospital that I work in. So let's get that out there right now. Right, without further ado, on to the news. So I want to just point out Amit's tweet here. Point of care gastric ultrasound, or POCUS. Now, gastric ultrasound's become very popular of late, and in particular, it's become popular to do with Wegovy or semaglutide. This is an anti-diabetes drug that people are taking now for weight loss. Problem, if you're starved for an anaesthetic for 12 hours since midnight or whatever, if you're on this drug, you probably aren't starved because it delays gastric emptying fairly significantly. So you need to beware and be very careful about starvation status. Oh. Indeed. So be careful. If you don't take an adequate drug history on your patient, you may have an aspiration on your hands. And this is where gastric ultrasound may come in handy, because if you put the probe in the subxiphoid region and scan look at the gastric antrum, it may in fact be full when they thought they were starved and they weren't. So there you go. This is an interesting paper, and there's an article in the BBC all about it. It's hit the news. It's hit all the front pages of the press. And as it's discussing, the other side to this drug is there may be some evidence that, like when statins were the thing in the 90s, this drug may in fact be decreasing the incidence of myocardial infarction, diabetes, obviously, and other things if you're not diabetic already. So there we go. It could be a good thing.
Goodness gracious.
Indeed. So moving on from that news, and we're now going to go on to the trawl of the best websites.
Check out the crazy websites.
Indeed, check out the crazy websites, or not so crazy websites, because I want you to look here at criticalcarereviews.com. Rob McSweeney, absolute legend. He has the best meeting ever, which occurs here in the Titanic Centre in Belfast. And there's the Game of Thrones set there, if you really care about that sort of thing. By the way, dragons are not real. Exactly. Can you believe that? Dragons are not real. I had to explain that to my wife. Because she used to get dinosaurs and dragons muddled up. Indeed. So they're not real, but that's Game of Thrones there. Rob McSweeney's meeting. All the best researchers come together and present their data before everybody else hears about it. So you must go to that meeting. Anyway, Rob's website, if you click on it, you get absolutely heaps and heaps of all sorts of things like newsletters, you get papers and all sorts, and my link isn't working to that one, oddly. But so let's talk about this one here. And this is a fabulous paper in the European Heart Journal supplement section, all about the golden hour and shock management. Do a lot, do it quickly. You must read it because it defines shock, because we're all a bit rubbish at defining shock. So if someone asks you what it is, some people really struggle to get the adequate definition out there. And indeed, it's a systolic blood pressure below 90 for some period of time. There's a definition on mean arterial pressure as well. And also there are the clinical signs that are well documented down here. So I quite like that. And also this Society of Cardiovascular Angiography and Interventions in 22 comes up with an at-risk beginning, classic, deteriorating and in extremis versions of shock. And again, you've got your systolic of 90, mean of 65, and that's the usual choice that we pick on the intensive care unit, of course, isn't it? So it's all in there. Anyway, aside from diagnosis of shock, it mentions quite clearly quite a lot about point of care ultrasound, and you'll see it all here, and it's discussing lots about the heart, the IVC, and various other things that point of care can help us with. And it includes hemodynamics and the use of trending, such as velocity time integral, VTI, if you've never heard of that before. It's a way of assessing a preload status of a patient, whether they're going to be preload tolerant, not fluid responders. We don't say that anymore. It's preload tolerance team. So it helps you to determine all of those things, whether they need vasopressors early, and indeed how you should maybe decongest your patients via VEXUS scanning, lung B lines, all sorts of things in there. So do have a good look at this article. And there's a lovely graphic at the very end which tells us all about the golden hour and the different phases of shock, and here it is for you to download. 0 minutes to 30 to 60 to 90. And interestingly, the shock team is in here. And if you've got a shock team, it's a hub and spoke system. So if your patient's in refractory cardiogenic shock, you might want to refer them to a shock team who may pick them up and give them mechanical circulatory support. If you think that's voodoo, that's fair enough, because I know a lot of the research has shown that things like Reboa and stuff that's a tad different, maybe of zero benefit, and we might be jumping in too early and putting too many lines into these people. So there you go. So there we are, shock teams.
Say yeah!
Indeed, say yeah to shock teams. There we go. Next paper I've picked out from Rob's beautiful list. I don't know how he does it and has enough time, but he's amazing. Fair play to Rob. I want to give Rob a round of applause, by the way, because I think what he does is fantastic. So Rob, round of applause there. This one's about acute kidney injury and point of care ultrasound and liver cirrhosis. Now, the problem with liver cirrhosis is that you can't interrogate the hepatic venous waveforms like you normally would, so you've got to skip it out. If you're doing VEXUS to decongest the patient, it's IVC, big, go on to next step, hepatic vein, check the waveform out, check the portal, and then go on to the kidneys. But you can't do those two middle sections if the patient has cirrhosis, because it don't work. So this is all about paying more attention to the kidneys. And one thing that is interesting is that, let's say you've got a patient on the filter and you want to know if they're going to trial off successfully and produce urine later on. I would check a renal resistive index. So we're going to talk about this in a second, but you check out the venular and arteriolar waveform in the periphery of the kidney. You put a Doppler through, and you get a certain arterial waveform and a venous waveform below. And the morphology of that waveform can tell you lots of different things. There's another paper I'll talk about later, which goes into real detail about all of this stuff. Here's some nice graphics about it all, and they go into some very detailed classifications and why it's convenient to use POCUS in patients with cirrhosis who've got acute kidney injury. The reason, again, is they may need some decongestive help, some natriuresis, not just diuresis, and they may need filtering to actually offload them and help their liver status improve. And also the point of care stuff, check out the jugular vein, check out focused ultrasound, which is cardiac, things about LV function, lots of funky things in there, the RV size, pericardial effusions, check for ascites, check the state of the urinary tract, and then the VEXUS, like I'm talking about, and we're going to tell you more about VEXUS in a short while. So that's fab. Next paper I picked out was this one, Quality Indicators in Intensive Care. Now, I don't want to go into massive detail, but if you look at this table here, it gives you some fantastic quality indicators that you could look at. For example, if you wanted to an audit recipe book or something of that ilk, I think there are lots of really good tips and tricks in here. And in fact, I think we'll probably start one at Northampton, having me found this. So please do go to this paper and check out these quality indicators. Does your ICU meet these? If it does, another round of applause for you. There you go. So moving on swiftly, let's look at some other things. And the next thing I want to point out, so that's Rob McSweeney's website, that's criticalcarereviews.com, but I think it would be very good to check out this next website, which is The Bottom Line, which is one of my favourites. Here it is. The Bottom Line is a group from Wessex. They started off by breaking down papers into nice palatable chunks. We all know that reading evidence and papers can be a little bit, should we say, dull at times. So this makes it palatable.
Oh my God!
And it makes it palatable. So as Homer said, oh my God, please look at The Bottom Line. They are fantastic in the way they've done things. Breakdowns, analysis, and then the bottom line at the end of the paper. So what have I picked out from The Bottom Line this week? First one is non-invasive airway management of comatose patients in acute poisoning. What this is looking at is whether it is prudent to intervene immediately with a patient who's suffered poisoning and a decreased GCS and intubate, or leave them for a bit and observe them, versus going straight in for it, putting the metal inotrope in and popping the tube down. And the results really conclude that if it is simple acute poisoning, jumping in far too early and intubating may increase length of stay, increase morbidity and mortality, and it may give them a worse outcome overall. So that was a very interesting paper, but bear in mind, patients with a GCS of 8 as that sort of linchpin point of do you or don't you intubate them. Well, actually, GCS of 8, simple poisoning, perhaps observe them for 4 hours, and if things are deteriorating, then tube them. So withholding it actually may improve the composite endpoints of in-hospital death, length of stay on ICU and in hospital. So the bottom line here is in patients with a GCS below 8, due to simple poisoning, leave them for a bit and observe. There you go, isn't that fantastic? So there's a lovely paper, and in fact it puts a bit of a blunter on what we'd normally do, which is jumping in with GCS of 8 and tubing. Let's not do that, perhaps. Lots of stupid sound effects in this, but that's just me all over, isn't it? Right, next. The AIRY trial. Now, this is the use of rifaximin for hepatic encephalopathy. Gastroenterologists all recommend this, and certainly you may jump in and give them rifaximin immediately. But what this paper is saying is the use of rifaximin with your normal lactulose protocol versus placebo and lactulose. Is there a difference in the time to improvement of the encephalopathic state? Now, what this trial shows, and by the way, rifaximin is an antibiotic and it is not well absorbed orally, so it sits in the gut, and it does kill off quite a lot of the nitrogen-producing bacteria, which cause worsening of ammonia levels in the encephalopathic state.
Nice.
So that's great. What this paper has actually said is that the addition of rifaximin doesn't result in early resolution of the encephalopathy. In fact, but it also doesn't reduce the incidence of infection or endotoxin levels. I think the key to this paper is that if the patient, if for whatever reason, is unable to have lactulose, then the addition of rifaximin may be of some benefit. So rifaximin, do you, don't you? Well, this paper certainly gives a signal towards no benefit in addition to a normal lactulose protocol. So that's quite interesting. And then finally, the next paper I have picked out is the Profi-VAP study. Now, what this is, in patients with severe brain injury requiring tubing intubation, does early single dose of ceftriaxone compared with a placebo reduce the rate of ventilator-associated pneumonia? So there's a great question. Does it? Well, in fact, what the data is giving a signal towards, as I'll show you here, so it's a divisive topic, and they mention this because ventilator-associated pneumonia is very hard to define. We all struggle to define ventilator-associated pneumonia, but what this paper has demonstrated is that an early dose, single dose of ceftriaxone may prevent early ventilator-associated pneumonia in patients with severe brain injury. It may also decrease antibiotic and ventilation exposure and mortality without any safety risks. So I think the bottom line on this one is we should probably, in our severely brain injured patients who are at risk of VAP, which is many of them, give them a very early dose of ceftriaxone. There we go. So that's fantastic. So on to some of the things now. So let's have a look at some of the papers that we've pulled out.
Here are the best papers.
Indeed, Emily, thank you. Here are the best papers, and let's take a look. What have we picked out here? Anesthesia journal goes within this is a paper about the intubating conditions, essentially, using remifentanil versus neuromuscular blocking drugs like we normally do. Was there a benefit? Now, essentially, this study showed that Remi is a safe and good alternative where neuromuscular blocking drugs need to be avoided for whatever reason that might be, but they need further studies because we all know there are hemodynamic effects associated with remifentanil bradycardias and atrial standstills and all manner of things if you're not careful. Got to be honest, I do give a decent slug of this stuff, a mic per kilo, in fact, to patients who I've got doing awake regional anaesthesia on, and the surgeon is doing a really big manipulation of the shoulder prior to clearing it all out. Because even with a block-in, good interscaling block, the patient still feels the extremes of movement. So a careful dose of remifentanil alleviates that, and you've got a nice, stable patient all the way through. And I guess it's a similar thing when they're having such a big stimulus to the airway with laryngoscopy. So this paper is discussing the benefits, risks, and side effects and so forth of using Remi versus NMBs, and it is a variable feast, but it is eminently doable. So there we go. Good paper there. Thank you to Anesthesia. And this paper here, again, thank you to Anesthesia and the team. Laycock et al. Have produced a lovely paper all about the healthcare professionals' perceptions of pain management on the intensive care unit, because I think we are not good sometimes at dealing with pain on the intensive care unit. Oh. Yeah, you may indeed say, but we tend to forget this and prioritise things like sedation and tube tolerance and stuff. But we mustn't forget pain. There are some fantastic free text boxes within this study that it's really good to read, because it really highlights that there may be some problems in perceptions of the way pain's dealt with, the way we're trained to deal with it, and many other things aside from. So that's a really lovely one to read, and it highlights why pain relief and analgesia on intensive care is so important. Now, the next paper here, and for some reason it's saying can't find the server, was all about VL versus DL. Now, I don't know why these links aren't working, but the argument for video laryngoscopy versus direct laryngoscopy seems to continue fruitfully on Twitter, for example, X, whatever you want to call it, and Instagram things. Nobody seems to be able to agree. People who are against VL say it's taking the skill away, and direct laryngoscopy is the way we're all trained. It's the tradition. What if you haven't got VL? All these things. What the paper has shown, and the link is down on the sheet, which you can all download later, and apologies, I don't know why it's not working. What it's highlighting is that VL gave better conditions, less grade 3-4 views on Cormack and Lehane, and really it's saying that perhaps time to decent view during rapid sequence induction may be improved with VL. So look, argue all you want, VL versus DL. I think it's a difficult one to know, and actually I couldn't give a about which is best, because you just need to secure the airway, and you don't want a can't intubate, can't ventilate, and can't oxygenate situation. Done. There we go. So that's interesting. So I thought I'd point those out to you. And the next thing I think we should go through are some pics of POCUS. And of course, this is my absolute love, POCUS. So what have I picked out here? Now, I could talk about POCUS till the cows come home, but I'm not going to bore you too much. So what have we found this time round?
You've got to see the best POCUS.
You do have to see the best POCUS, and this is what I'm going to show you. Right, first and foremost, now you'll see there's a big list here. I'm not going to go through the whole lot because it goes on a bit, as you can see. Let's pick out some of them. You can check the rest out in your own time. The ZU crew. I must talk about ZU Ultrasound. They're Australian. They do some fabulous work. They are prolific on Twitter, and they mention other people's work a lot as well. But what they do is they crunch down all of the best ultrasound stuff that's gone on throughout the week on Twitter. So it saves you a load of time, and actually it's really good learning material. So I would encourage you to check out ZU. They've got all sorts of stuff here, loads of images, loads of beautiful things. And they even have stuff like how to make your own phantoms, if you're sad enough to want to do that in your own home. Ordering ballistic jelly, by the way, can be a bit of a problem for the police if they find out you're ordering kilos worth of the stuff. Just saying. But they do show you how to make your own phantoms and stuff. So it's a really, really beautiful newsletter they do, and hats off to them. And in fact, they deserve a Johnny Wilkinson round of applause. ZU, well done for everything you're doing with ultrasound. Fabulous. And next we are going to jump into POCUS. Here is Abhilash, and he's talking all about VEXUS. So let's listen in and see what he has to say.
Scan. So to do a VEXUS, you can use either a phased array transducer or a curvilinear transducer. I generally prefer curvilinear transducer because we are scanning the abdomen. And phased array, the settings are
so
more
talking
optimized
over
for,
him. If anyone doesn't know
scanning.
him, he is a prolific
Feel like
nephrology
when doing Doppler, you might have
intensivist
to
in the
adjust
US,
a lot of
and he
settings
can
like
do
scale
almost
and wall
everything.
filters,
His teaching style is phenomenal. He
to
uses lots
suit
of
for the
graphical
abdomen.
representations, and I love
And when
everything
using
he does.
curvilinear
He's talking about
you
venous
put that in
excess
the
ultrasound
cardiac
here,
preset.
how to
It depends on the machine,
how
but
to
my machine
decongest
allows
your
the
patient if they
EKG
are
to be
congested.
run
I just want to
simultaneously,
zoom
only
across
when it is in
to him talking about hepatic venous waveforms, because here he goes.
Because in inspiration, your forward velocities increase.
Let's just have a listen
and
to
in
this.
expiration, your above the baseline velocities increase. So this is a normal hepatic vein waveform. Maybe we'll get one more with the patient holding breath. That way you'll see that it appears more
Sorry,
uniform.
actually,
Let me put the
answering
color
a message
again.
on my phone there.
And
Can you
once we
believe
find
that's
the vessel
my
better,
wife
we can ask
interrupting a
them to hold the breath.
podcast?
Okay,
That's
sir, can you hold your breath?
ludicrous, isn't it? Ludicrous.
Now you can see that the
So yes,
waveform
he's
is
talking
much
about
more
hepatic
uniform.
venous waveforms, the A and the S and the D
Thank you very
waves and so
much.
forth and so on, and
Here
what
you
they
have
are
the
and how
systolic wave,
they
followed by
can
V
change when you
wave,
decongest
the
your patients.
diastolic
So
wave,
do watch this
and
video
here is
all
the
about VEXUS. I'm going to close the volume off now. And obviously loads of people are giving him props for doing this. So Johnny Wilkinson, a round of applause for NephroP. We love NephroP. Just quickly, we're going to talk about extended VEXUS, which is the normal VEXUS that you will learn about when you have a look and watch his video. But extended VEXUS, aside from hepatic veins, portal veins, kidneys, now goes and looks at the spleen and the femoral vein and the right internal jugular vein and, in fact, the SVC as well. Interrogation of these venous waveforms can give us indications of when patients need to be decongested. So he gives a beautiful tutorial all about that. So that's really fantastic. So well done, NephroP, and thank you for everything you do. And can you believe my wife is still trying to message, even though I've said I'm podcasting? There you go. Right, what have we got next? This one I'd encourage you to look at. It's all about renal stones. And here's a lovely one. This is a patient who presented with transient limb numbness. And if you have a look at this image, this is a parasternal long axis view of the heart, and I hope you can appreciate it. You've got the left atrium there where my cursor is. There's the left ventricular cavity. Here's the aortic valve. And if you look at this right coronary cusp at the top here, it's very, very, very thickened. I don't know if you can appreciate this very thick right coronary cusp. And the reason it is thick is because the patient has SLE. And as a result of that, a thrombotic condition, and that is in fact a thrombus that was visible on the valve leaflet. So it was very bulky, and after some weeks of anticoagulation, you can see that thrombus has in fact cleared up completely. So really good POCUS images of a parasternal long axis showing thrombus on the right coronary cusp of the aortic valve. So really nice from Edgar there. So thank you to him for showing us that image. Lots about VEXUS again. This is now here's a lovely one. This is an incidental scan shown by IM-Crit, and I love IM-Crit stuff. But if you look here, here is the liver. Here is a bit of gallbladder looking a bit thickened and so forth and so on. Here is probably an end on hepatic vessel of some type. Here is the superior mesenteric artery, pancreas sitting around there. And here is an enormous IVC going inner to inner wall, and this huge thrombus in the middle, and there it is zoomed in, and also there it is with colour flow over. Barely any flow getting over the top of that thrombus there, so very interesting to see that scan. Thank you to IM-Crit for pointing that out to us, so that's really handy. And then what have I picked out next? Well, it kind of goes on and on. There's one all about renal ultrasound and how detailed you can get with it. I'm not going to go into the intricacies. Please click the link and have a read of this tutorial, because it goes into some detailed stuff, which is almost transplant medicine, actually. And here is one about a patient presenting in cardiac arrest on the intensive care in a state we call pseudo PEA, pseudo pulseless electrical activity. Because when you put the probe on, even though there's no pulse, there's an ECG, there is, as you can see here, some cardiac activity going on in the LV and around the mitral valve area. So in that situation, it is encouraged to not necessarily jump back on and do CPR, but in fact push vasopressors because the outcomes could be improved. And indeed, achievement of ROSC can be improved in that circumstance when you don't go back and do CPR and give more vasopressors like adrenaline or noradrenaline or whatever. In pure PEA, you won't see any contractility at all, but here's the pseudo PEA again in the short axis view, just shown on that image there. So that's lovely. Thank you to them for showing us that. What else have I got? So I've got some stuff about DVT. And the reason I've put this in here is because I think DVT is a badly done thing, DVT scanning certainly. But if you look at this image here from the crew at Sonocritic, you can see the saphenous veins up here. Here's the femorals and the femoral arteries, as you can see there. And here is the femoral vein, and there is a thrombus. You can see it there. When you press down, as they're doing, the thrombus becomes more visible. And of course, in DVT, what happens is the vein walls, they are incompressible. So when we press normally, they should close off altogether and open again when you release the pressure on the probe. In a DVT, they barely compress at all, as demonstrated in that really lovely clip there. So thanks to them. DVT scanning, promotion is a good thing to do for your patients, any suspicion of them. And it's very simple to do as well. There's some stuff about RV Doppler. And now here's something I want to point out. This is a big debate I started stupidly on Twitter about should you scan in plane or out of plane when you're doing vascular access. So I put a poll on, see what everyone's doing, because I do in plane. So that's long axis of the vessel, excuse me, watch the needle coming in, and then place the appropriate catheter in. However, doing a little Twitter poll of 139 people, 73% do out of plane, which is fine. It's absolutely fine. And that there was a lovely little graphic somewhere in here which showed a little animation of in-plane and how you can actually scan and find the true needle tip. Because this is always the problem when you put the needle in. When you're out of plane, you put the needle in and you don't know where the tip is, because if your ultrasound beam is crossing the needle here, it still looks like the tip when the tip's down there. So what they're advocating is scan, move down till it disappears and then just reappears, and that's where the tip is. So I can't find the graphic on here, but there was a really tasty one. But just have a look at the Twitter feed here and it should pop up somewhere or other. It's hidden within here somewhere, but I can't remember where. There we are. So in plane versus out of plane, clearly out of plane is favoured for vascular access. Not my favoured one, but you know, everyone's different, aren't they? And then this is one about CVP and the IVC. So let's move on. Please dig into all of those POCUS grabs I've done there. And now we're going to have a look at some regional.
Stop before you block regional anesthesia.
Thank you, Emily. Regional anesthesia, my other love. And let's take a look at some articles that I've picked out here. This is actually one talking about erectospiny plane blocks for rib fractures. Great thing to do. Fusic blocks, I'm writing. It's forthcoming soon. We're doing a big session at State of the Art in Liverpool, the ICS meeting. We've got 75 minutes all about thoracic wall blocks and blocks for intensive care, so please come to the session. What this is saying is, we know that ESP is a sensory block, okay? But you can still use a nerve stimulator, and actually they will get a sensation in the sort of dermatomal area where you want to block. So this paper is discussing the use of nerve stimulation where you wouldn't in fact think it's worth doing. Amit's papers are all in here. Look, he's all over the place. He's a great guy, Amit Power, a good friend of mine. And he's done quite a lot of work into Plan A blocks and stuff with RA UK. So that's interesting. And the other side to it, which comes in further down here, this is sorry, apologies. This is RA UK. I was there a couple of weeks ago. Fantastic meeting, Regional Anesthesia UK. Go to the BJA and have a look at all the abstracts which are appearing as a special supplement in there. Lots of really lovely regional anesthesia, loads about fascial plane blocks and all manner of stuff, so check that out. This paper's from Hari Kalagara, a good friend and a fantastically prolific regional anaesthetist and POCUSologist, if you like. This paper here, he's highlighting, is discussing the use of Botox into the wound walls of some abdominal hernias, particularly complex ones. What he's saying is if you put Botox in, paralyse the muscles of the abdominal wall, the opposition and closure is better. They get better healing, better cosmetic result, and so forth and so on. So I just thought I'd pick that out because I found that a very interesting paper. I guess it's not strictly regional anaesthesia, but very interesting nonetheless. Robbie Erskine and team. Robbie was a boss of mine at Derby's, fabulous chap and a great teacher. He's talking about his specialist area, which is, using hyperbaric prilocaine for ambulatory regional anaesthesia and spinals in day surgery. Something we might all be a bit petrified of, actually. Someone's coming, I don't know, for a knee arthroscopy or a hernia repair, say, put a spinal in and they're still moving their legs, and you think, ooh, this is a bit, but it does work very well. He's got it down to a T, and here's his recipes for you. So thanks, Robbie, and the team for that. Do check that out. Jeff Gadsden, Professor Jeff Gadsden and team are discussing failed peripheral regional anaesthesia here and what to do. It's a nice supplement in the BJAD. And Jeff does a fabulous podcast with Amit Power called Block It Like It's Hot. It is hilarious. The pair of them are like a couple of plonkers on it, but it makes for fabulous teaching, very humorous style. In fact, I'm doing one with them on Monday, all about Fusic blocks for ICU. So do watch out for Block It Like It's Hot Fusic ICU blocks. Lord knows what's going to happen with myself, Amit and Jeff on the same podcast. It could be disastrous, but I think it should be very amusing. So do tune in for that one. And anyway, this is a really nice supplement all about what to do in failed regional anaesthesia, because, sometimes they don't work. We're not all amazing at them. So you've got trial and error behind you at times. The bunch at RA UK and Alan McFarlane here has done a nice tweet highlighting the work of Jenny Ferry and James Bowness, all about research questions in regional anaesthesia. Have a look at this paper because, again, this could be a really good one for you to audit within your department, see whether you're doing a good service to your patients in regional anaesthesia. So well done to the team for that paper there. And then this one, this is all about outer plane anaesthesia, in plane. There you go. There's the thing I wanted to show you. So there was my poll. And if you have a look here, here's this lovely video of how to actually find the true tip of the needle in the outer plane approach. So you can see here, the probe is moving away, nothing. And then just at the point where the tip comes in, stop, that's the tip, not the mid-hub of the needle. So you can do it. So hats off to whoever did this animation. Who's done that? I don't know, Neil? Well, there you go. Whoever Neil is, well done for the animation. Really love that. Going to pinch that for teaching. I think Aidan Barron's saying the same thing. So that's regional anaesthesia. So lots of lovely stuff there. So what else have we pulled out for you? Well, obviously loads of graphics and tutorials and things like that. So I'll show you what I've found here. And as I've always said, I think images tell 1,000 words or speak 1,000 words. So let's have a look at some of these lovely ones that I've pulled out from Twitter and places. Here is the fabulous Leah Al-Hilali. I can't pronounce this. Al-Hilali. Leah, I apologise. Al-Hilali. There you go. So Leah is extremely good at producing these almost nephro-P style tutorials. And this is all about cerebral vasospasm after subarachnoid hemorrhage. Why it happens, how it happens, what to do, how to treat it and stuff. Please have a read because it's absolutely brilliant. And I love graphical representations, graphical teaching. It's not everyone's bag, but it's definitely mine. So well done, Leah, for that one. Anesthesia are producing some nice new insights into anaphylaxis. Take this, print it off. Everyone's badged it up, including, it's a shame the ICS isn't on there, but we're not, never mind. So do take that away. ECG patterns, love this. Some great cardiologists giving tutorials. Here are some lovely patterns you would maybe never see in your lifetime, but if you do, you'll recognise them now. Take a look at all of these he's put down here. Really, really sweet teaching. So a Johnny Wilkinson round of applause goes to Leah and also to Jack, EM Note. And actually, Jack may have done these himself, so hats off to you. If I had a hat on, I'd take it off to you. And here is a very clever person who is talking all about ST elevation MI equivalents, and included in here is that notorious posterior MI. Look at this, really well explained why it happens, why there's this morphology. I used to remember turning an ECG round upside down and looking at it through the light, and you'd see an ST elevation in the posterior leads as 1 to 3. So this is discussing loads of things like that and various other things, and it goes on and on. It's a really, really good one to get really clued up on your ECG, so well done to him for that one. Indeed, there's a lot of claps going on.
Nice.
Andy gets a nice as well. Yeah, that's brilliant. We're getting to the end now. Here's pancreatitis and a nice algorithm. What I like here is it says correct hypovolemia, but be careful, don't overload the patient. Please don't overload the patient, because it's... And I get absolutely, utterly off when patients come in having had 15 litres of fluid, when really it's a vasoplegic state and they need vasopressor. So just be a bit careful with your patients with pancreatitis and don't fluid overload them. Please, please, please don't fluid overload them. There you go. Popping noise for no reason whatsoever. Do take a look at the pancreatitis paper I've highlighted there. JVP, I love these graphics that occasionally appear, really beautiful teaching graphics that we used to see back in the day when you went to cardiology clinic. This patient, I don't know what position they're in, but it's showing beautiful jugular venous waveform that's elevated. So we, particularly people like me with POCUS, rarely do clinical examination the way we used to. That's one disadvantage of POCUS. Put my hands up that maybe I use these less and my stethoscope not at all anymore, sadly. But these clinical signs are gold dust when you can see them. So thanks to Dr. G. Rajesh for this fantastic work. Ashley goes on about shock a lot. So does Eddie, and he's pulled out some really nice papers about shock. Read this one. It's a really nice one teaching about that. And then we do have said Ashley Miller, great friend of mine, fellow intensivist anaesthetist. He is one for a hatred of fluid overload, as I am, as Justin Kirk-Bailey is, as Andy Breen is, and all of us who are in the Turning the Tide group. You'll hear more about that soon. And he's discussing vasoplegia and how fluid overload occurs and how shock is not a one-size-fits-all thing. So well done, Ash. Congestive cardiac failure post-MI. Nephro P pulls out some fantastic graphics. Here's another one. Check that one out. And he's done it for pulmonary hypertension down here as well, as you can see here. So really nice graphics. I love the way he finds these and pulls them out and advertises them on Twitter. So that's really kind of him to do, because I wouldn't spot half of these things. Good. So that is my pick of sort of the graphics and so forth and so on. So now we're going to move on to something to do with, we're going to talk about courses and things we might recommend. So
Which courses should I go on?
Which courses should I go on? I wish I could do the same accent, but I can't. So there you go. So which courses? I've picked one because I could go on forever about this. Okay, so Oxford have got a fabulous, evidently, this page doesn't exist course. They've got a regional anaesthesia course, which was in this link here. Is it going to work? No, it's not going to work, is it? That's really disappointing. So I'm going to plug it now. So Oxford have got a regional anaesthesia course I really think you should go on. And their regional anaesthesia course is all about pain on intensive care and intensive care related blocks. ESP, SAP, spinal ultrasound, how to do it. They've got femoral nerve blocks, fascioiliaca blocks and for hip fractures and things like that, and various other things. Within our FUSIC blocks for ICU module, I'm doing superficial cervical plexus for lines. We're doing all the thoracic wall blocks, including ESP, SAP, paravertebral, and we're doing spinal ultrasound. We're also doing rectus sheath blocks, discussion of parasternal blocks, because they can be a bit dicey, particularly if you hit blood vessels underneath. And there are many other ones in there. So please check out that Oxford Regional Anaesthesia course. I'm sure you can Google it somewhere. I don't know why that link doesn't work. They were working before, but hey-ho, diddly, etc. So next thing we're going to talk about are obviously podcasts.
Podcasts.
For some reason, Emily found saying podcasts really amusing. Not sure why, but
Podcasts.
she burst out laughing at the end of it. So anyway, there you go. My mother's now ringing me. I mean, how do these people know? Have they got like some kind of vlog detector or how to be irritating detector for Johnny's phone? Anyway, there we go. So podcast. Here we go. Here is Block It Like It's Hot. Listen to this.
Okay, man, let's get back into it. So I want you to imagine that I'm your resident, and I know because of that vast age difference between us, it's not that much of a stretch of the imagination. So let's talk about how we're going to perform.
Right. So ideally a curve probe, that's what you're going to need for the majority of patients, and that allows you to see.
That's Amit and Jeff Gadsden talking together on their Block It Like It's Hot podcast. You must tune into these. You must subscribe to it because they are hilarious, the pair of them. And as I said, gratuitous advert, I'm doing one on Monday with them both, which will be all about Fusic and blocks for intensive care. But they've got such a great style. I love what they're doing, and you must tune in because it's really good learning as well. Within humour is learning, and that's what I always say. And without humour in learning, I think it would be dull, but that's just my opinion. I think they've hit the nail on the head. That's Block It Like It's Hot podcast. Now, Chris Yap, a good friend of mine, an ED consultant from Sheffield, he does POCUS Club. He's done loads and loads of stuff in here, and this is Manoj's regional wall motion abnormality POCUS Club, which I think Chris has made these available to download or certainly watch later on YouTube. So please have a look at all of that. And I must mention as well Echo Nepian's YouTube channel, because they do some phenomenal teaching on YouTube as well with all things cardiac and POCUS indeed. So Chris Yap and POCUS Club, I'm doing one in a few months when I actually give him a date that I can do, but yeah, he's doing some great work there. And then finally, the Crit Care Commute team. Crit Care Commute. Now, the Crit Care Commute team are a bunch from Canada. There's Professor Pete Brindley and Leon Biker, and now there are 2 UK correspondents, me and Marcus Peck, my very good friend and colleague. So we're the UK correspondents on the Critical Care Commute podcast. Please download and join in with the Crit Care Commute podcast. It is brilliant for all things intensive care. And I think if we click here, we might be able to watch some kind of video. Here we go. Let's just see. Oh, here. What could go wrong? Marcus Peck, Johnny Wilkinson, Pete Brindley and Leon Biker together on one podcast. Even worse than Amit and Jeff. I mean, can you imagine? All sorts could go wrong on that podcast. Struth. Do they know what they're doing? Well, I think they do, but I think we're going to have lots and lots of fun, so please check that out. Let's hear Emily again.
Podcasts.
I mean, why is podcast so funny to a teenager? Maybe it means something else. I mean, I'm not as youthful and down with the kids as I used to be. Right, finally, I want to mention some meetings.
Which meetings should I spend my money on?
Which meetings should you spend your money on now? Obviously, meetings are important. CPD is important. And do you know what, right? I can't find the server again. I don't know what's happening here. But when I did the first guys of this morning, incidentally, didn't switch the mic on for the entire 50-minute podcast. Idiot. It all worked. But this was just a video about RA UK and how they've changed their logo. I used to really like their logo, but they've changed it nonetheless, and it still looks amazing. But I used to love the previous Regional Anesthesia UK logo. So RA UK have changed their logo, guys. And that there was a video about it here, which now no longer works, which is fabulous. And then, oh, this works. Look, Sono UK. This is an ultrasound festival which happens once a year. Here it is. It's in my fantastic hometown of Newcastle upon Tyne, where I'm a Geordie and now, and it features loads. Look at this: emergency med, general med, anaesthesia, intensive care, paediatrics. The whole bunch come together, and we all teach ultrasound. We go and have fun together, and we network. So please book Sono UK 24 Bob Jarman's meeting. Hats off to Bob for doing this for many, many years now. And in fact, he's going to get Johnny Wilkinson cheer. Professor Bob Jarman. In fact, Professor Bob Jarman, I love you. There you go. So that's Bob Jarman and Sono UK. And the final thing I want to say is this has been the first Critical Care Northampton vlog. Now, I hope it's been okay. If you're listening to the podcast, I get it. You haven't seen the graphics, so you might not be understanding exactly what I've been talking about. But I hope I was descriptive enough relatively so that you could get a basic idea of what we're discussing. Please subscribe to the podcast when it comes out. Please follow the YouTube channel. And all those links you've seen here, I'm going to put down onto the bottom of the YouTube channel. And I will also include it on the website as well. Also, gratuitous link. Please, if you've got time, check us out at Crit Care Northampton. I've moved up there. I didn't realise that had happened either. Some weird stuff's happening with this camera. But if I move, it follows me all over the room. It's quite freaky. Anyway, please subscribe to Crit Care Northampton up there. Go down on the website, put your email address in, and we'll keep you posted with all these vlogs, loads of newsletters, POCUS. There's all sorts of learning resources on there and things like that. So I just want to say thank you to everybody for tuning in and listening. And also, let me know what you think of the theme tune. Because actually, I did this. So if you like drum and bass, you might like the theme tune. If you don't like drum and bass, you'll obviously hate it, but just do let me know in the chat somewhere what you think of the theme tune, and I'm going to be doing more, hopefully, as the weeks go by. We'll change it, we'll change the graphics up and stuff like that. Listen, everybody, take care of yourselves. It's been lovely to have you on this podcast and vlog. Take care with all things Crit Care. Cheers.